Dankjewel. Oep. Thank you. Wow, so many people. Wonderful. Probably not for me, but for Kate. But I'm happy to report today on our study on income and risk solidarity in the Health Insurance Act. So what do health insurance and solidarity have to do with each other? Some will say everything, others will see it differently. In 2009, I attended a lecture in the healthcare financing course that I was following. The lecture was attended by students from all over the world, and Professor van der Ven explained that the healthcare financing system in the Netherlands rests on the principles of solidarity. The discussion that followed this statement revealed that solidarity is not a given. It depends on social preferences, political, color, and culture. We know from scientific literature that people often particularly dislike health inequality due to income or risks. They find it worse than inequality in any other aspect of their lives. There's also a term for this, health inequality aversion. Research shows that although countries may differ widely in the way they redistribute public spending, people in general, regardless of their country of origin, care about health inequality and would like to see it mitigated as much as possible. Nationwide health insurance is one way to ensure accessibility to care, regardless of your income or your health needs. We have just learned from Professor Baker's presentation that insurers add value by providing access to care. In the Netherlands, therefore, solidarity was an explicit consideration when the Health Insurance Act was introduced in 2006. The pre-2006 system consisted of both private and public health insurance. There was a strong desire to have a single system. And within this new system, there also had to be room for competition. But at the same time, Dutch politicians, both left and right-wing politicians, were concerned that a private healthcare system would lead to inequality between rich and poor and healthy and sick. Solidarity between incomes and risks was therefore explicitly stated as a precondition in the new law. The new system thus ended up being a private system with a social character. A private system with a social character, how does that look like? Well, competition in the new health insurance system was based, among other things, on the introduction of a nominal premium for everyone, insurers bearing financial risks, a profit allowance, co-payments, and enrollees' ability to switch between insurers annually. The social character of the new health insurance system resulted from the introduction of measures to ensure risk and income solidarity. Risk solidarity was guaranteed, among other things, by an individual mandate for health insurance, health insurer's obligation to accept all enrollees for health insurer, and a ban on premium differentiation. All Dutch citizens are obliged to buy a standardized individual basic health insurer package from a private health insurer. For the basic health benefit package, health insurers must accept all enrollees. And premium differentiation is also prohibited. This means that health insurers must demand the same premium for everyone with the same health insurance policy. The system also includes a risk equalization system, which is, as we just learned from the presentation by Professor Baker, among the most elaborate in the world. Income solidarity was guaranteed by the introduction of the income-related subsidy and a statutory health insurance subsidy covering the payment of the nominal premium and the deductible. The resulting law was the Health Insurance Act. The Health Insurance Act covers curative care, or we sometimes call that cure. Curative healthcare includes all the care aimed at improving or maintaining health except long-term care, because that's called long-term care. The Health Insurance Act includes various forms of care, such as general practitioners, medical specialist care, mental health care providers, pharmaceuticals, oral care, paramedical care, district nurse care, and obstetric care. The study I present today charts how income and risk solidarity in the Health Insurance Act is organized and works out in practice. But let me start with the definitions. Income solidarity in healthcare means that people with higher incomes contribute more to the payment of healthcare costs than people with low incomes. Sorry, can I go back? Yeah, I can. This principle is based on the idea that the broader shoulders bear the heaviest burden, and that people with low incomes should also have access to good and affordable healthcare. The more households with higher incomes contribute to healthcare and to the financing of that healthcare system, compared to households with lower incomes, the greater the income solidarity is. Risk solidarity means that the payments for healthcare are made by everyone, regardless of their health status. The principle is based on the idea that the healthy shoulders should share in the burden of people in poorer need. For example, in a society with a high degree of risk solidarity, chronically ill people do not have to pay the full cost of their expensive treatments themselves. These costs are co-paid by people who have little or no healthcare costs. Risk solidarity is complete, that's how we call that, complete risk solidarity, when payments to an individual healthcare expenditures are independent of the amount of that individual's healthcare expenses. The degree of income and risk solidarity indicates how household contributions to the Health Insurance Act are distributed by income and healthcare expenditures. Income and risk solidarity thus says something about redistribution between households within the Health Insurance Act. But it doesn't say anything about how these contributions affect household purchasing power or the overall degree of redistribution in the Netherlands. Previous research shows that redistribution also occurs through other governmental expenditures. Our study describes household income and risk solidarity in the Health Insurance Act in 2019. We follow the scientific literature and look at solidarity between households, so that's the unit of analysis, in 1 year, 2019. We distinguish the following payments in the Health Insurance Act. The nominal premium is the same for every insured person who chooses the same insurance policy. The deductible is mandatory, and the amount of the mandatory deductible is set annually by the government. In 2019, it amounted to €385 per year. The income-related contribution is paid by citizens, often through their employer. The law establishes a 50-50 split maintained by the government. This means that 50% of the funding of total Healthcare Insurance Act healthcare expenditures is through the income-related contribution. And the other 50% is through the nominal premium, the deductible, and the general taxation. The government has established by law that healthcare for children up to the age of 18 years old is free of charge. They pay no premium and no deductible. The government finances the care costs of children through a state contribution for children. The state contribution is financed through general taxation. And at last, people with an income below a certain threshold receive a contribution from the government for the cost of their health insurance. This is called the health insurance subsidy. The health insurance subsidy is also financed by the government through general taxation. The health insurance subsidy is intended for people to be used by low-income citizens to pay for the nominal premium and their deductible. To get an idea of how the Health Insurance Act is actually financed, we first look at the size of the financing flows. Since the health insurance subsidy is a subsidy for the nominal premium, we present the nominal premium minus the health insurance subsidy in the rest of this presentation. We eventually thus distinguish 4 financing flows: the income-related contribution, payments under the mandatory deductible, general taxation, and the nominal premium minus the health insurance subsidy. The focus in the Dutch policy debate in recent years has mostly been on the level of the deductible. The deductible is paid by people who use care. The study shows that the other financing flows account for a much larger share of the financing under the Health Insurance Act. First, let us look at the results for income solidarity in the Health Insurance Act in 2019. In absolute terms, higher income households contribute more to health insurance funding than lower income households. This figure shows the Health Insurance Act funding in absolute terms by 100 percentiles. We again divide funding into the 4 financing flows. Households in the lowest income quintile contribute on average about 2,500 euros per year to the financing of the Health Insurance Act. This amount increases steadily as income increases. Households in the highest income quintile pay an average of about 10,000 euros per year. That was in absolute terms. If we now turn to the relative terms, we see another picture. In relative terms, lower income households actually contribute more to Health Insurance Act funding than higher income households. This figure shows health insurance financing as a percentage of the adjusted gross household income. It follows from the figure that relative spending in the Health Insurance Act increases to about 11% of gross household income for households with gross income around the 35th percentile. After the 35th percentile, the curve begins to decline. And we see that high income households contribute less to healthcare as a percentage of their income. The highest income quintile contributes the most to health insurance funding in absolute terms, averaging 10,000 euros, but the least in relative terms, averaging 6.6% as a percentage of their gross household income. So how is it possible that middle-income households contribute a relatively large amount, whereas high-income households contribute relatively less? To understand that, let's take another look at the previous pictures, but now not just on the shape, but also at the colors. The only financing flow that increases as the household income increases is general taxation. The contribution through the nominal premium minus the health insurance subsidy increases, but is fairly constant for the highest percentiles. This is because the higher income households are not entitled to a health insurance subsidy. The absolute co-payments made by households through the compulsory deductible are also relatively constant across income percentiles. So the relative contribution decreases for higher percentiles. In the case of the income-related contribution, the absolute contribution increases in the higher percentiles. As a percentage of income, however, the income-related contribution decreases for the latter income percentiles. That is because the income-related contribution is constant for all households above a certain income threshold. You can see that in this figure. In the figure you see that the income-related contribution is capped. Households with an income above 56,000 euros pay a fixed amount of income-related contributions. I'm showing you the picture of the size of the financing flows again. The size of general taxation is relatively low, only 15%. Since this is the only financing flow that increases with household income, payments to the Health Insurance Act decrease in relative terms as household income increases. Next, we come to the results for the risk solidarity. Household risk solidarity is high in the Netherlands. The left-hand figure shows healthcare spending by all households. The x-axis shows the total healthcare spending for households in 2019, with households ranked in ascending percentiles. The graph shows that households in the lowest percentiles have hardly any healthcare spending, while in the highest percentiles, a household's healthcare cost can be very high. For example, households in the top percentile of this graph have on average around 90,000 euros of healthcare expended each year. If households had to pay these care themselves, many households would be in financial difficulty. The measure of risk solidarity indicates the extent to which household healthcare expenditures are distributed evenly among households. And that is what is shown in the figure on the right. The y-axis shows the contribution of all households to the Health Insurance Act in 2019. The different colors again indicate the different financing flows. If we compare both graphs, it is clear that risk solidarity is high. The contribution in the right-hand figure are fairly even distributed among households, and for all percentiles, the average contribution never exceeds 7,000 euros. For example, in the highest percentile, the average contribution is around 6,000 euros, which is considerably lower than this group healthcare expenditures, which was around 90,000 euros, while the contribution for the 25% of households with the lowest healthcare expenditure averages 5,000 euros. We do not observe full risk solidarity, which would be the case if every household contributed the exact same amount to healthcare. I now come to my conclusion. Although high-income households contribute more to the financing of the Health Insurance Act in absolute terms, this is not the case if we look at the share of income. Risk solidarity among households for the Health Insurance Act is high, and financing flows contribute to the Health Insurance Act funding in different ways. I began this presentation by explaining how income and risk solidarity took shape in the Health Insurance Act. The social character of the Insurance Act was a major point of discussion when it was introduced. We now conclude that risk solidarity in 2019 is indeed high. When it comes to income solidarity, however, we conclude that it's relatively low in the Netherlands in 2019 compared to previous research and research from other countries. We saw that is mainly the case because of the income-related contribution is capped, and for all households above a certain income threshold. An important question is how we should interpret this result for policymakers, and how much solidarity do we need? I began this presentation by stating that solidarity is not a given. The degree of solidarity depends on the social and political preferences. As a society, do we think it is important for everyone to bear the same or equal burdens? Or do we think that the stronger shoulders should bear a heavier burden? A burden that is, for example, proportional to their income. Another important consideration is whether the system is sustainable. Because of income solidarity, middle income contribute proportionally more relative to their average use of care. When healthcare costs rise faster than income, which is the case in the Netherlands, this leads to an increasing reliance on middle-income households. Risk solidarity, on the other hand, ensures that healthy people contribute more to the cost of people who need care. As healthcare costs rise, the gap between the cost and the benefits of care of healthy and release widens. Middle income and healthy and in release may then perceive the payments to healthcare as disproportionately high. The pressure on the degree of solidarity then increases. If it becomes too much, can people opt out? And how much solidarity do we want as a society, and how much can we bear? It remains a trade-off. I'm very keen to hear how our next guest, Barbara Guzine, Director General of Curative Care of the Department of Health, and you, the audience, will see this. Thank you.